pharmacology. This is going to be a video that discusses specifically pharmacodynamics. And pharmacodynamics is going to be about the study of drugs and how they act within the human body. So we are going to be discussing specifically how drugs act. And this will be the third of the 4 in the series. I'm going to first discuss the mechanism of action. The mechanism of action is how drugs will produce their effect. Furthermore, then we'll get into pharmacodynamics, which is the study of drugs and their effects on the human body. And part of that pharmacodynamics study involves pathophysiology, or the study of how diseases interact with the human body. To understand drugs, we first have to understand receptors. And the analogy we're going to use here is a lock and key. And a lock and key talks about how drugs are going to bind to a particular cell to produce the effect that we desire. And the better the key fits, the better the affinity for the drug, meaning the stronger that it's going to bind to that cell and stay there. The lock is the binding site. So if that key fits that lock, then we ultimately have a drug that's going to work. Fighting for a receptor. Some drugs have a higher affinity for a receptor and will bind better. Drugs with a lower affinity can actually get kicked off. And some drugs even fit multiple locks, meaning some drugs can activate one receptor and causing activation of another. Typically, you might see that in immunizations as a prime example. Drugs that are agonists will fit a lock and allow you to turn the key. Now, I have 3 doors to my house. 2 of those doors fit with one key, and one door has a different key. And if I put my far back door key in my back door lock, it's going to turn. And when I turn it, it's going to open the door, meaning there's actually going to be an effect when I use that key on that particular lock. And those are called agonists. Agonists will activate a cell that was turned off. Now, if they are an inverse agonist, they will turn off a cell that was turned on. And if they are a partial agonist, they may actually act like an agonist in some cases and antagonist in another. We'll talk about that in the next slide. And when 2 agonists compete, the agonist that fits the lock better will bind. And you typically see this when you use more than one opioid. So let's say you have a patient who is on OxyContin and then they are also on Norco. Well, let's say their cells respond better to Norco. They can take the oxycodone and it'll bind. It'll probably give them some pain relief, and they may actually need something to knock that oxycodone off temporarily to provide better pain relief, and that's where the hydrocodone comes into play. So if the lock is better suited to binding to that receptor, it'll bind and it'll kick off the other one. Opioids bind, by the way, to a opioid receptor in the body, and they mimic the body's natural endorphins. Endorphins are created when your body gets a lot of action. So let's say I go down to my local trail a couple miles down the road, and I get out my rollerblades and I rollerblade for 15 to 20 miles. And I'm not immune to rollerblading every 15 to 20 miles. That is not an uncommon occurrence for me. But let's say I rollerblade 15 to 20 miles. I get back, I'm going to feel an emotional rush of endorphins. And that is my body telling me everything is fine. Now, the next day I'm going to feel like absolute crap because all of those endorphins are going to wear off and all the muscle damage I caused by rollerblading 15 to 20 miles is going to catch up to me. What is going on there is your body is sending an everything's fine response. And that everything fine response is going to result in pain relief. Antagonists are drugs that fit the lock but do not allow that lock to turn. Now, go back to the case of my front door and my back door. My front door has a different key than my back door. If I put my back door lock in my front door, the key is going to go in because the lock was made by the same manufacturer as my back door lock, because that's the way I bought my locks when I bought my house. But if I put my back door lock in my front door lock, the key is going to go in, but it won't turn. Now, that's not going to cause any action to happen. I'm not going to get in my house any faster because that key is now in that lock. Now let's say the lock had some water in it and then we immediately got a winter freeze while I'm standing outside trying to figure out that I'm using the wrong key. Um, Meaning my key now has a higher affinity for the lock than it did before. I can't use my other key now that I need to use because I can't get that key back out. That's how naloxone works. It will block the action of an agonist, an inverse agonist, and a partial agonist. And that is sometimes true, but not always. And we'll talk about that in the example I give you right underneath this. And the example I'm going to give you is naloxone will block the effects of an opioid agonist, so oxycodone and the like. There are a couple of partial agonists, pentazocine is one, and buprenorphine is another, that are partial agonists. Partial agonists can act as an antagonist. Remember I said in the last slide that partial agonists can act as an antagonist if they are taken with another opioid. So let's say a patient shoots up heroin and then we give them buprenorphine. In that particular instance, the buprenorphine being a partial agonist in the higher concentration of an agonist, the heroin, will actually act as if it is an antagonist. Meaning, if I give the patient naloxone, I'm going to counter the effects of the heroin, but I am not going to counter the effects of the buprenorphine because the buprenorphine is already acting in the body as if it's an antagonist. So it will not knock the buprenorphine off of the same opioid receptor, unlike heroin, where it will kick off the heroin. Naloxone is one of those drugs that does block the effects of opioid agonists because it is an opioid antagonist. And it will knock it off. It will knock the agonist off, and it'll reverse the effects of the agonist if it was exhibiting those effects because it will turn off the agonist. This creates an interesting drug interaction. And I'm going to get into drug interactions in our fourth video, so I'm not going to get too deep into the subject right now. But sometimes the use of an agonist or an antagonist is contraindicated, meaning it should not be used. And I give the prime example of beta blockers in asthmatics, because this is a very specifically labeled contraindication. Beta antagonists, beta blockers, in asthmatics will actually trigger asthma attacks. But because they have very high affinities for those beta cells, it may also render the beta receptor agonist, which is the emergency asthma drug that we give patients to open up their airways, it may actually render that drug completely useless. So giving patients who are asthmatics beta blockers is a very dangerous combination. Also, there is a concept called a competitive antagonist. If it binds, it creates absolutely zero effect on a cell, meaning we turn it off and turn off all of its effects. The drug that is considered to be a competitive antagonist, by the way, is a very weak drug, meaning you're going to need whopping doses of it in order for it to actually work. Non-competitive antagonists are drugs that combine with another part of a receptor and deactivate it. They negate the effect of an agonist. This, a non-competitive agonist would be naloxone, just as an example. Enzymes, channels, and transporters all work in the same process as receptors, except the terminology is a little different. So in the case of drugs that act within enzymes, so if you need an enzyme to activate a drug, for example, you're going to need a prodrug, meaning you're going to need the drug that metabolizes by an enzyme to create an active drug. That would be a agonist style effect. An inhibitor blocks the normal reaction of an enzyme, and if you use an inhibitor, that enzyme is turned off and does not create any metabolites. In fact, it may even create what's called false substrates or abnormal metabolites. That is a drug interaction that ends up happening within enzymes, and we'll talk about how that works again in the next video, so I'm not going to get into that topic very deeply here. Channels are another avenue for drugs to actually act. Channel blockers are blocking the permeation of a channel. Prime example of that is the calcium channel blockers, meaning when you take that drug, the calcium channel is blocked within the heart so that additional conduction is not allowed. Modulators increase the opening of the channel. So if a heart does not beat enough, we may need a calcium channel modulator to increase the opening of that channel. I don't know of one of those off the top of my head because I don't believe one exists. Transporters are agonists and antagonists in their same like, but they do this with ions, meaning they use it with an electrical charge. So an antiporter exchanges ions across the membrane and activates it. That's an agonist style reaction. A symporter extrudes ions after binding to a membrane that creates an antagonist effect. Next, we're going to talk about dose responses. Now, in theory, if you increase the dose of a drug, you're going to get a greater effect. And that effect is called a dose response curve. You will see that as a lovely little picture in a package insert somewhere, and it's displayed graphically. But before we get into that, I need to go into a little bit of terminology. So here comes the boring part. My apologies. Efficacy is how well the drug works. So is the drug effective within the body? And at what point is it effective? Potency. A drug that has high potency will produce great effects in low doses. Fentanyl, primary example of that, it's a drug that we measure in micrograms. And little changes will produce much greater effects much more quickly. So high potency drugs have really, really low doses. Drugs with high doses that produce minimal effects have low potency. Think about amoxicillin. There are some patients that need 875 milligrams of amoxicillin in order to get the needed effect in the body. So when we start talking about doses that are in the hundreds of milligrams, we are talking about drugs that have low potency. Then there's the ceiling effect. That happens when all drug receptors are saturated. Opioids are a primary example of this. There is no labeled dose of opioids. Go looking in the package insert if you want. I've got time. You can pause the video. Feel free. Go grab any opioid package insert right now, pause the video, and try to find a max daily dose. You didn't find it, did you? It doesn't exist. The max dose for an opioid is patient dependent. And that max dose is achieved when no more pain can possibly be relieved, meaning all of the opioid receptors are saturated with opioids. So that's the ceiling effect. Then the last thing that we talk about is therapeutic index. Now, therapeutic indexes are based on half of the patients that take a drug. Lethal dose, I'm going to abbreviate that in further information here as TD, which is toxic dose. So the lethal dose is divided by the effective dose in 50% of the patients is the therapeutic index. The lower the number, the narrower the therapeutic index, the more monitoring you have to do with the patient. Let's take lithium as an example. Lithium is one of those narrow therapeutic index drugs. A narrow therapeutic index drug has a very low potential of ability between the effective dose and the toxic dose. And lithium, the effective dose is 1 milliequivalent per liter of blood volume. The toxic dose is 3.5 milliequivalents per liter of blood volume. Not a wide range of numbers there. In fact, that leads to a therapeutic index of 3.5 because if you take 3.5 and divide by 1, you come up with 3.5. That's nice, easy math. For those of you who don't like it, there's your easy math for the day. So the therapeutic index of lithium is 3.5. Gabapentin has a therapeutic index of 163.3. Now, what that means, that therapeutic index means, is for lithium, the toxic dose is 3.5 times greater than the effective dose in 50% of the patients. Now, in gabapentin, that number is 163.3. So, The effective dose in gabapentin for 50% of the patients is 0.3 grams or 300 milligrams. The toxic dose, the only dose I could find at toxicity levels, because by the time gabapentin becomes toxic, it knocks you into a coma, is 49 grams. Um, you would have to take a lot of gabapentin to get to 49 grams. Um, that would be essentially taking about 56 800 milligram tablets. Not exactly something I'm going to run out and do today. So gabapentin has a larger therapeutic index than lithium. So I have a lot more play with gabapentin. I don't have to monitor that therapy as carefully as I would lithium. And that just determines whether or not a drug really requires routine monitoring in order to become effective. Coumadin is another one of those narrow therapeutic index drugs. Again, its therapeutic index is about 3.5 as well, and that's based on an INR ratio. So some drugs actually do work better than others, and I give you this as an example. So drug A in this dose response curve. These are dose response curves, by the way. So, drug A, a very small change in dose will create a substantial effect. That also means drug A is going to plateau quickly, meaning its ceiling effect is going to be achieved at a much lower dose than you would expect. Drug A is likely going to be some type of receptor agonist. Now, graph B, that linear line there, means that dose changes are generally done incrementally. Drug B is likely going to be a partial agonist or an antagonist. And that is because the higher the dose, the more linear response you are going to get out of the drug. This is what it looks like in terms of side effects. So again, the dose response relationship. So as we go from no effect to death, death being a toxic dose, by the way, we are going to encounter some different side effects. So we may actually be able to see the dose response in terms of the side effects a patient is going to receive. And we're going to talk about that as we go through the last bit of considerations for pharmacology or for pharmacodynamics. So other considerations may be the patient immune response, desensitization of drugs, unexpected reactions, psychological factors, and adverse drug reactions. And we will talk about those in turn and use up the last bit of our half hour doing that. So let's talk about our patient first. Patient considerations when it comes to drug action is going to include age. Our body changes over time, especially when it comes to hormones, fat, and the like, and may result in changes to our body metabolism of a drug. Weight, dosages may need to be adjusted for weight. This is pretty common in pediatrics. So I do a lot of omeprazole compounding in my pharmacy, and the common drug that we see for omeprazole, dosing wise, is 1.5 milligrams per kilogram per day. And so if you give me a patient weight, I can calculate a dose based on that information. So it's very common in pediatrics because your patient's going to weigh 2 kilograms this year because they're a neonate, and they're probably going to weigh 4 kilograms or more next year because they're not a neonate. So that dose may change over time because as patients grow up, they get heavier. Gender is a common problem or common consideration we have to come into play. And when you look into a lot of drug studies, you'll see that they actually do test men and women separately to see if the effect is different, especially fat absorbed drugs, because in women that can actually be higher than in men. Muscle and fat ratios are different between men and women, and that has to do with the fact that men have higher levels of testosterone in their bodies. So their drug effects could be higher or lower based on their particular metabolism. Genetics is another consideration, and this is particularly important for enzyme and protein acting drugs because you may or may not have the type of enzyme that needs to be used to change the drug into an active form. And if you are missing that particular enzyme, the drug's not going to work for you. That is becoming a brand spanking new level of pharmaceutical practice called pharmacogenomics. And pharmacogenomics is going to probably rapidly change how we actually dispense drugs in this country. And as soon as we could get some of that nailed down a little bit more, those tests nailed down a little bit more, I think you'll be seeing genetic tests being used to determine a patient's propensity for a drug working or not working. Then there's diseases. Patients with liver, kidney, and lung diseases are not able to metabolize drugs as well as healthy patients. So we do have to consider that as we go through dosing a patient. And also pregnancy. And not in the way you think. Yes, it does change the way we choose drugs for patient use, but it also changes how drugs are metabolized in the body because the digestive tract is actually slowed down in pregnant females in order to allow the patient to have more food absorbed into the body, more nutrients absorbed into the body for the additional life that is growing inside them. So because their digestive tract is slowed down for that response, you may actually see delayed drug actions as well. Immune responses. These are allergic reactions. Now, this can be either to the drug or the excipient. And I work in compounding pharmacy. We see a lot of patients who tell me that they give me a list of 20 allergic reactions that they've had to drugs. And if you actually were to put all the pieces together, it's probably not the drug. It's probably an excipient of that drug. The allergic reaction can range from mild, say a rash, hives, to severe, which includes swelling and airway obstruction. Obviously, if a patient is exhibiting swelling and airway obstruction to amoxicillin, I'm not going to give them amoxicillin because the risk of that giving it to that patient is too great for me to absorb in liability insurance. So we do tend to take into consideration what type of allergic reaction the patient had. Now, an allergic reaction does get worse over time. So keep in mind that a mild allergic reaction that a patient may have had 5 to 10 years ago, if they've continually kept taking the drug, they may be on their road to severe allergic reactions real soon. Desensitization. This is often called tolerance or repeated exposure causing a decreased response. And we typically see this with the opioid class. The benzodiazepine class is also not terribly far behind on its heels. And basically what happens is because of the chemical changes that are exhibited within the body responds differently to those drugs. So you may actually need a higher dose to continue keeping that therapeutic window open. So that's why you typically see patients going up in doses in opioid land versus down. Unexpected reactions. These are unpredictable effects. We call them idiosyncratic effects because they are not in sync with what we expected to find in the drug. And I'm going to give you the 3 Z's, zopiclone, zolpidem, and zaleplon, as a prime example. I call those the 3 Z's of pharmacy for the records. Those are the anxiolytics. Those are the drugs that cause you to sleep. Since there's 3 of them, it's really easy to remember them as the 3 Z's of pharmacy. But the 3 Z's of pharmacy are intended to cause sleep in a patient. Well, let's say that you have that one odd patient who, instead of causing sleep, it causes the patient to act as if you had given them an entire pot of coffee. That would be an idiosyncratic effect because that is not what we expected that patient to exhibit. Then there are the psychological effects. The placebo effect, the mindset that a drug will do good things. Then there's also the nocebo effect, which is a mindset that the drug will do bad things. Now, one thing to consider about this is that thoughts and feelings in the placebo effect and the nocebo effect are independent of the actual drug action within the body. You could probably draw a blood level on the patient of a particular drug if that test is available in a placebo and a nocebo patient and probably draw a level that you would expect to see, but your side effect profile doesn't match up because the patient has a psychological belief that something different is happening. Lastly, I'm going to get into adverse drug reactions. Adverse drug reactions are side effects, and 10% of your patients will experience side effects. The populations most at risk for this are patients who take multiple medications and patients who are elderly. Not terribly uncommon that the elderly take more than 10 medications a day, and a patient who's in the hospital is typically on 10 plus medications anyway. But what happens is those risks for drug interactions that we'll talk about in our last video of this series go up substantially. Now, side effects can be mild: drowsiness, dizziness, stimulation, things that you can live with if they don't become too severe. Severe side effects, respiratory and cardiac depression, which generally lead to coma and death, are considered to be severe effects. Now, we also have drugs that are hepatotoxic. Acetaminophen is a prime example of a hepatotoxic drug, and hepatotoxic drugs cause liver damage. Nephrotoxic drugs cause kidney damage, and a typical class for that would be the NSAIDs. Tetrogenicity, the drug's ability to cause harm for a fetus. I believe one of the other two videos in this series already addresses the levels of teratogenicity in the fetus. And the FDA does have a category listing for it. It is worth noting the FDA just recently announced that they are going to change the pregnancy ratings. They're actually going to eliminate them. So keep an eye out that you may actually see those pieces of information change. Carcinogens are the ability of a drug to cause cancer. Dependence and tolerance refers to controlled substances. And that is the ability of a drug to cause physical or psychological need, meaning that once a patient becomes dependent on a particular dose, you may need to up the dose in order to achieve a continued clinical effect. Or if you're abusing the drug, you may need more of that medication as well. As far as patient adherence goes, there are 5 steps to creating a patient adherence routine. One, the patient must believe that the drug is beneficial. If they do not believe that they're going to benefit from the drug's effects, they're not going to take it. 2, if they have drugs that cause adverse reactions, if it makes them feel like absolute crap, they're probably not going to take it. So you may have to consider that the adverse drug reactions are causing a patient to decide whether or not they want to take the medication. Creating a medication routine, meaning getting them in the habit of taking the medication. A lot of pharmacies are coming up with compliance aids, either using pill trays or medication timers. There's a few apps on phones that are allowed to do that. I often encourage my patients to actually set reminders on their phones to take their medication, and sometimes that helps as well. Ensuring that a patient understands their therapy schedule. I have one patient who has now been in my pharmacy 3 times in the last 3 weeks for medication that should have lasted 30 days, and he keeps telling me he's running out of medication. No idea why, unless he's actually opening the bottle and just drinking what he thinks he needs. So understanding how his therapy schedule needs to be done, and also how his medication needs to be measured. And lastly, affordability. I'm going to give you a couple tools to help your patients afford their medication more, especially now that we're in the era of high deductible plans. One place to go for patient assistance programs is called NeedyMeds, NeedyMeds.org. They have all, if you type in a drug name, they have all of the patient assistant programs for that drug. The other place I'm going to send you is the Patient Assistance Foundation. Their website is copays.org. And what they will do is they will help patients with copays through using grants. They're a nonprofit organization. They do great work. I've used them on a few different patients, and it does help them afford their medications more, especially when you're talking medications that cost thousands of dollars. In the last couple of minutes that I have, patients that report in adverse drug reactions should be reported to the FDA by a pharmacist. It's Form 3500 in human medicine. It's Form 1932A in animal medicine. So if you do veterinary pharmacy, you do have to report that on a different form. Patients can contact the FDA directly. The phone number is on the bottom of every monograph that you give the patient. That little piece of paper that no one reads. That's where you would find it. It's also at the bottom of your sales receipts in the pharmacy. So keep that in mind. Why do you do this? It improves the public health. because there are a lot of things that we don't study on drugs. And if we don't study it in clinical trials, it may come up after marketing has started for a drug, and the FDA needs to be aware of it. Propoxyphene is a fine example of that. 2011, propoxyphene was removed from the market because we determined that the drug cardiac risks were much higher than the benefits that the drug provided. So the FDA determined at that point in life to get it off the market faster. So we can revise the product labeling, or the FDA may determine that it needs to be removed from the market because it's not safe. So keep that in mind, that we do fill these forms on adverse drug reactions to improve the public health, and that ultimately is the goal of healthcare in the first place. Well, I hope you enjoyed this video. We have one more video left in this series. We're going to talk about drug interactions and medication errors and their effect on your practice of pharmacy. And I thank you for joining us. I hope you enjoyed it. If you haven't caught the other two videos yet, I strongly encourage you to go back and take a look at them.